Hello, good afternoon. I'm Dr. Yap. I'm the senior anesthetist from the Faculty of Medicine and Health Sciences, University Malaysia, Sabah. I'm going to talk to you several important neurophysiology knowledge today. And these are my topics this afternoon. Regarding about cerebral physiology, cerebral blood flow, dysregulation, intracranial pressure, types of intracranial bleeding and our anesthetic management, and specifically, I'm going to share my experience doing awake cranioplasty and its anesthetic considerations. Okay, so without further ado, I'm going to talk about the brain physiology. Our brain weighs about 1.2 to 1.5 kilogram and is about 2% of our total body weight. And not surprisingly, because of its active neuronal activities, it consumes about 15% of our cardiac output and 20% of the oxygen consumption as well. Okay, as we know, our cardiac output is about 5 liters per minute, and then about 15% of it goes to the brain. Its cerebral blood flow is about 50 mils per 100 gram per minute, and approximately 750 mils per minute is for in the adult population. Okay, so in the gray matter, the higher flow occurs. Okay, because of active neuronal activities, the neuronal bodies occur in the gray matter, while the white matter consumes lesser blood flow. As mentioned earlier, 20% of the body oxygen goes to the brain to sustain its active neuronal activities. Okay, and then specifically the CMRO2, the cerebral metabolic rate of oxygen, CMRO2 is about 3.3 to 5 mils per 100 gram per minute. Thus, in a 1.5 kilogram weight, is about 50 mils per minute at least. Okay, the cerebral metabolic rate of oxygen consumption, the CMRO2, means the oxygen demand of the brain to sustain its activity. Because of this as well, the glucose consumption is higher at about 5 milligrams per minute. This is a very important slide to talk about the regulation of the cerebral blood flow, which can be categorized to either intrinsic or extrinsic factor. Cerebral autoregulation is an intrinsic mechanism to maintain its cerebral blood flow. Importantly, metabolic, myogenic, neurogenic, and also the pressure regulation. Extrinsic chemical factors such as the partial pressure of oxygen and carbon dioxide plays an important role too in the regulation of cerebral blood flow. Same goes to the temperature, the blood viscosity, and the sympathetic nervous system. This important chart shows the coupling of the cerebral blood flow and the CMRO2. It is a linear correspondence whereby an increase in the demand of the CMRO2 will have to be met by an increase in the cerebral blood flow. Okay, as you can see from this chart, it's a linear relationship. So the higher the CMRO2, the higher the cerebral blood flow has to meet the demand of the oxygen in the brain. This is also another pressure autoregulation chart, which shows the cerebral blood flow and the mean arterial pressure relationship. As you can see here, in normotensive adults, we are tightly regulated at 50 to 150 millimeters of mercury in the mean arterial pressure, okay, whereby the cerebral blood flow will be sustaining fixed or constant at 50 mils per minute. However, in chronic hypertensive patients, the entire chart has to be moved to the right side, as you can see in the blue chart. Okay, so their mean arterial pressure to sustain autoregulation is to be higher, okay, about 120 to 150 millimeters of mercury. Not shown in this chart as well is for the neonate, which will be swerved slightly to the left side, okay, because of the narrower mean arterial pressure or immature blood pressure regulation of the neonate. Thus, they are slightly shifted to the left of the normotensive adults to sustain the cerebral blood flow in the neonate as well. Chemical regulation does have an important influence on the cerebral blood flow as well, especially the partial pressure of carbon dioxide and the oxygen. As seen in this yellow graph, you can see at the range of 20 to 80 millimeters of mercury of carbon dioxide, there's a linear increase in the carbon dioxide and the blood flow. When the cerebral blood flow is increased, there's massive vasodilation. Okay, muscle vasodilation occur and there's increase in the cerebral blood flow to the brain. When there's a massive increase in the cerebral blood flow to the brain, there's an increase in intracranial pressure. I will talk about this in the next segment. So it is not good to have a massive blood flow to the brain, and this will cause cerebral edema. Okay, patients will have a reduction in the Glasgow Coma scale. Above this 80 millimeters of mercury, however, there will be a plateau, okay, whereby the maximum vasodilation of the cerebral vessels will occur. Same goes at the extreme of less than 20 millimeters of mercury of partial pressure CO2. The massively, it will be massive vasoconstriction occur, okay, at the ends of the range. Partial pressure of oxygen has minimal effect, okay, on the cerebral vasculature, except for if it is less than 50 millimeters of mercury, there will be an increase in cerebral blood flow will occur, whereby massive vasodilation in action to massively increase the blood flow to the brain, so the oxygen supply is maximum. Okay, massive vasodilation occur if the partial oxygen pressure is less than 50 millimeters of mercury. This is an important chart, okay, pressure and the blood flow. Okay, so it combines the mean arterial pressure, partial pressure oxygen, and the PaCO2. Okay, so these are the combined effect of these various pressure on the cerebral blood flow. I'm going to talk about the cerebral perfusion pressure. Okay, the cerebral perfusion pressure is a net perfusion pressure to allow blood flow to the brain. Okay, cerebral perfusion pressure, the CPP, equals the mean arterial pressure minus the intracranial pressure, or the mean arterial pressure minus the central venous pressure, the CVP, whichever is higher. The normal values of a CPP is about 70 to 80 millimeters of mercury. All right, so it's approximately the same value as a mean arterial pressure, assuming there is no increase or the no presence of an intracranial pressure in an adult. Now, this is a topic about the intracranial pressure. The intracranial pressure in the brain, okay, as what I can see in the brain here. Okay, so in the brain here, you have the constituents of three major items. You have the brain parenchyma, you have the blood, and also the cerebral spinal fluid. The constituents of the brain parenchyma is about 80%, while the blood volume is about 20%, and the CSF about 5 to 10%. Okay, and it is a very rigid bulk which consists of these things. So therefore, the potentiality or the potential of the brain expansion is limited. Therefore, because of this, brain is in a rigid bulk. Okay, so the compensation will only occur through a reduction of the CSF, the blood, or the brain parenchyma through the foramen magnum over here. This is a foramen magnum, as you can see, a revision of your year 1 medical student anatomy. Okay, all right. So this is the way of how we measure the intracranial pressure. Okay, so intracranial pressure, we have various methods to measure the intracranial pressure. The intracranial pressure can be measured by the EVD, okay, the external ventricular drainage, the EVD placement. Okay, so this picture shows the measurement of the EVD, which is most precise way whereby the neurosurgeon will insert the probe, the intracranial probe into it, and then measure like our central venous pressure monitoring. Okay, so it goes into the lateral ventricle, okay, and then you will have to measure it externally. Okay, so this is the method of the measurement. Now, same as our pressures, they have all the waves that are present. Okay, they have P1, P2, and P3. Okay, in this is picture number 1A. It shows the P1, P2, and P3. P1, it shows the arterial pulsation. P2 is the one that we have interest in, where is the intracranial compliance. And P3 is our valve of the aortic valve closure, which creates there's a dicrotic notch over there, pressure here. So our interest is in the P2, all right? When the P2 is severely increased, okay, like an increase in intracranial pressure, intracranial compliance is reduced. So there's an increase in the pressure here, okay? So this is a dangerous sign, which means that the ICP is raised, okay? So this is a ICP waveform, okay? So now I'm going to talk to you regarding our famous doctrine that called the Monroe-Kellie Doctrine. We mentioned earlier that in our brain, it's a rigid component that composed of its content of brain, okay, about 80% of brain parenchyma. The blood volume is about 10 to 15%. Our CSF is about 5%. Okay, so remember there's a foramen magnum down there, okay, which is serve as our escape route of the blood, CSF, and also the brain parenchyma. Okay, so in this picture, the intracranial mass occur, right? So when it is small, the brain parenchyma or the system can still compensate. Okay. However, when there's a massive increase in one of the mass, okay, when the mass is severely increased, there will be acute compensation will occur. Therefore, it is mentioned an increase in one component must be offset by a decrease of another component, okay, to prevent a massive increase in the intracranial pressure. Okay, so it is very crucial because initially, okay, when there's one condition occur, okay, increase in one of the component occur, the brain parenchyma or the brain system will try to compensate to prevent a massive increase. However, in decompensated phase, there will be a massive increase in intracranial pressure. Therefore, the patient will develop symptoms of raised ICP. Okay, so in this chart, I'm going to tell you about this, the pressure volume or the compliance, okay? The compliance chart. Again, when there is no massive increase in the volume, compensation is adequate, okay? The patient will be stable. There will be no presence of any signs and symptoms of increased intracranial pressure. However, as the compliance decreases, okay, so there is a increase in the intracranial pressure will occur. Patient may develop signs and symptoms of intracranial pressure. And this is a phase, okay, the red color is a place whereby the brain is ischemic, okay? When the brain is ischemic, because of the volume is increased, therefore the pressure will have to expand very fast. When there is an expansion of the intracranial pressure rapidly, there will be a herniation of various brain parenchyma, the tissue or the CSF going down. Okay, so the most importantly is that the brain parenchyma will have to go down. Okay, will be herniating through the foramen magnum. Okay, therefore the affected brain side will be the brain stem. Okay, the brain stem, okay, at the posterior fossa, okay, will be the most severely affected, and then it is a place of SOS occur, whereby all the sympathetic nervous system, the rapid firing of the sympathetic nervous system will occur, so that the brain can be acutely be revived. Okay, so to prevent the collapse of the cerebral circulation. So now I'm going to talk to you about the signs and symptoms of ICP, of raised ICP. Headache, blurring of vision, projectile vomiting, lethargicness, altered body consciousness and body weakness, seizures. Patients may have these signs reduced GCS, the Glasgow Coma scale, neurological deficit, okay, where they're having the motor or sensory loss, patient, okay, especially in children, they have a very tense fontanelle, okay, the anterior and posterior fontanelle, and then the enlarged head circumference, okay, so hydrocephalus patient, and you have the famous, you have the pupil asymmetry and the papilloedema. Cushing triad will occur, okay, if the patient is in severe cerebral ischemia, that I already mentioned earlier, hypertension, bradycardia, and respiratory depression. I hope all of my MOs and housemen know how to evaluate the best responses in the Glasgow Coma scale. Okay, so these are the brief. So in Cushing's triad, the pathophysiology is simple. Okay, when the ICP is very raised, okay, there's a reduction in the cerebral blood flow. Okay, the cerebral blood flow will be reduced. So when there's reduction in the cerebral blood flow, as what I mentioned earlier, the brainstem reflexes will have to be activated. Okay, massive SOS will be sent out from the brainstem so that there is a massive vasoconstriction, massive sympathetic vasoconstriction will occur so that there's increased blood flow to the brain. So patient will see hypertension and you will see an irregular breathing because of the herniation of the brain, stimulation of the brainstem reflexes. So you get irregular breathing, okay? And then you will see because the BP is too high, stimulation of the baroreceptors in the arch of aorta and the carotid sinus will occur, and then you get reflex bradycardia. So hypertension, reflex bradycardia, and irregular breathing is the Cushing's triad. In this segment, we are going to talk about various neurosurgical procedures. Because of the time constraint, I'm going to focus on three important items, all right, which you will always see during your on-call. Okay, we will see a patient with trauma, okay, decompressive craniectomy for ICB, intracranial bleed, patient will have extradural hematoma or subdural hematoma. Okay, so these are the types of common bleeds that we always see in our daily routine. We can classify into intraaxial or extraaxial hematoma. For intraaxial hematoma is the intracerebral bleed, means that inside the brain parenchyma itself. In extraaxial hematoma, it can be either a extradural, subdural, or a subarachnoid bleed. Okay, these are the simplest classification. I'm going to let you see this extradural hematoma, EDH. So you can see from this CT brain, you can see there's an extradural hematoma, which is biconvex in shape. Okay, so it is an active arterial bleed, which is the middle meningeal artery, which is occurring. So that's what is pushed. You can see it looks like a convex. Okay, it looks like convex shape. So it is active spurling of the blood occurring. And this is a very important sign whereby the swelling sign is there, means that active bleeding occur. So patient needs an urgent life-saving craniotomy. Okay, so this is due to trauma. Same goes to subdural hematoma. It can be acute and chronic, or chronic. Okay, depends on the patient's age. All right. So usually because of the subdural hematoma is because of the blood or venous connection between the dura and the arachnoid mater. Okay, it can be due to the tearing of the subdural veins. Therefore, it can cause a bleeding within this layer. It is presenteric in nature. So when you look at this CT scan, it's presenteric. So you can see that there is a subdural bleed. Okay, blood is always hyper. Okay, hyperlucency in this segment. So you can see that it is a blood condition. The content is blood. White is blood over here. Okay, it can be due to trauma. Common causes in elderly are cerebral atrophy, and some patients with overvaricalization, you can always see this type of presentation. Subarachnoid hemorrhage. Okay, you can see this bleeding within the subarachnoid space. You can see the finger-like projection. It looks like all those finger-like projections in the cerebral circulation. Okay, so you can see because of trauma also can cause subarachnoid bleed, or commonly is because of the aneurysm, ruptured aneurysm, okay, or an AVM. Okay, it can be a leaking aneurysm, ruptured AVM. Okay, it can be a ruptured aneurysm as well. Intracranial bleed, one of the commonest condition you can see because of the basal glandular bleed. It can be a spontaneous basal glandular bleed, okay, without chronic hypertension, uncontrolled hypertension, okay, intraventricular extension or intraventricular hemorrhage is common, okay. So these are the common CT brains that you can see. So whenever you receive a referral for this, this type of surgery or condition, you have to look out in the CT brain types of the intracranial bleed. Is it an intraaxial or extraaxial condition? The size of it, the volume, okay? The location of it is important, whether the patient is the supratentorial or infratentorial region, because the positioning will be different or will be difficult for us, okay, as an anesthetist, okay? Presence of cerebral edema, midline shift, and intraventricular hemorrhage. Like in this case, you can see there's a midline shift. You can see that there's the midline, okay, this is the midline condition, and then you can see that the entire ventricles, okay, the lateral ventricle is compressed, the right ventricle is, lateral ventricle is compressed, and it is shifted to the opposite side, okay. So the massive effect on the brain, okay, so that cause it to be massively being shifted to the opposite side. Same goes to this SDH, is creating a very big pressure effect on the brain, causing a right hand shifting. And then you can see that the cerebral edema, the gray-white dissociation, the differentiation is being reduced. You can't really see, okay, the differences over here. All right. So this is an important thing that you must look for. Okay, always look for these things because it will tell you a lot of information, the severity of the trauma, how long does the surgery will have to undertake, and what are the important precautions or anesthetic considerations that you will have to expect intraoperatively, and of course post-op management. Okay, whether the patient can be extubated, it can be or not, or patient needs cerebral resuscitation. That's very important. So you can see from this CT brain, as what I mentioned earlier, this will determine what type of surgery and the duration of it. Okay, decompressive craniectomy, craniotomy of extradural hemorrhage, and the EVD insertion, okay, for just an intraventricular hemorrhage extension, okay. And our role as an anesthetist is to prevent secondary cerebral insult, okay. Because of this primary insult has occurred, we have to prevent the secondary occurrence, and of course to prevent the death of a patient. Of course, we always see patients with head injury, okay, needing all this type of surgery. So these are our considerations. Patient with head injury, patient with full stomach, aspiration risk is very high. Patient will have an appropriate time to optimization. Let's say patient has an underlying chronic hypertension, diabetic, okay. The hypertension, the BP might be sky high, or the sugar is uncontrolled, okay. Commonly, patient be dehydrated, patient electrolyte imbalances. Of course, blood loss will cause patient to be anemic, okay, hypothermia as well, okay. And then patient might have any other trauma, cervical injury, intra-abdominal or intrathoracic injury as well. And you will have a lot of problem in resuscitating the ventilation. Of course, if patient is having severe maxillofacial trauma, you have difficult intubation, okay, and IV lines will be a bit difficult, okay. And then most importantly, you must look out for urgent or signs of raised ICP, okay. So with the presence of this raised ICP, you have to be careful, and you have to clear your OT fast so that the patient can undergo surgery rapidly, okay. So these are our anesthetic management for these patients with head injury. Okay, so when you use succinylmetonium, yes, it can cause a transient, okay, a transient increase in intracranial pressure. However, airway, okay, to resuscitate the airway is more important. So it depends on the patient's clinical condition. You can know hard and fast rule to say that no, cannot use succinylmetonium. So If the patient's condition is, difficult airway, or you think that there's airway is more important because of, patient full stomach, yes, you may use sustametonium. Okay. Yes, you may use the video scope to assist you in intubation, and of course, invasive monitoring for beat-to-beat monitoring. Okay, so on this aspect, again, it depends on what type of surgery you have to go. Let's say in a massive decompressive craniectomy, yes, I will usually use an arterial line monitoring with a CVL. Okay, adequate IV access is mandatory. And then, of course, analgesia, okay, is very important during their head pin insertion. Okay, so patient will be using the head pin. Okay, there's a massive sympathetic stimuli, so you don't want to have a major shift in your pressure. You want to maintain adequate cerebral perfusion. So if you increase the pressure, what will happen? The cerebral perfusion pressure will increase, raised ICP will occur because of cerebral edema. Okay, so you don't want further cerebral edema to occur by an unnecessary raise in ICP, unnecessary raise in cerebral blood flow. Therefore, you must control the pain with adequate analgesia. Like for me, I would like to use TCI remifentanil, all right, to maintain an adequate flow of the adequate blood flow. And of course, you want to avoid excessive neck flexion. Okay, and excessive neck flexion, okay, what will happen is that the venous outflow will be obstructed, therefore will cause an increase in the intracranial pressure. And these things is very crucial. We must make sure that the brain is relaxed for the surgeon to operate on, so that the secondary cerebral insult is being prevented. Now, what are the methods to prevent cerebral insult? These are the steps we can do as an anesthetist. Okay, 30 degrees head up position. Okay, avoid hypoxemia. Okay, make sure the ventilation is good, oxygenation is adequate. Okay, maintain normocapnia. Okay, we prevent hypercapnia to occur. That's why we maintain the adequate oxygen and CO2. Avoid hypo and hyperglycemia is important as well, because we want to maintain adequate glucose supply to the brain for the metabolism. Electrolyte imbalances can cause seizure, so that's why we want to avoid seizure to occur by giving your anti-epileptic medication. Your BP has to be controlled adequately with a cerebral perfusion pressure. Okay. Okay, you maintain CPP around 70 to 80 millimeters of mercury at all times. And of course, the temperature must be very tightly controlled at 34 to 37 degrees Celsius. Okay, anemia has to be dealt with urgently, because blood flow, okay, will depend on your hemoglobin. So your hemoglobin will carry oxygen to the brain, all right, transport. So if there's inadequate and hemoglobin, there is no blood flow, no inadequate blood flow, inadequate hemoglobin to carry oxygen to the brain for metabolism. And of course, you want to achieve an adequate blood flow to the brain by reducing the CMRO2, by achieving the burst suppression. So some pharmacological agent like propofol, thiopental is important to cause to achieve burst suppression, whereby there is no EEG. During burst suppression, there is no EEG movement, therefore the brain is relaxed. Avoid nitrous oxide, or let's say inhalational agent with a MAC of more than 1. Okay, if MAC is more than 1, there will be causing massive vasodilation in the brain, so it's not good for the brain. And whatever it is, TCI is versus inhalational agent, both are adequately can be used. All right, there's no any differences or outcome with the usage of TCI and the inhalational agent. As long as inhalational agent like sevoflurane is preferred, if less than 1, it is good. All right, there's no massive increase in the cerebral blood flow in the MAC of less than 1 of sevoflurane. These are the steps to treat raised ICP. It can be pharmacological or non-pharmacological. Okay, in pharmacological, we can use either diuretics of osmosis, mannitol, loop diuretics such as furosemide, and hypertonic saline 3%. Non-pharmacological methods are like the increase in the head bed, okay, the head of bed by 30 degrees, hyperventilation, right jugular venous compression, and also urgent decompressive cranectomy. Post-operatively, we can decide whether you want to extubate or not extubate. Depends on the preoperative, intraoperative condition of the brain. Okay, sometimes you can look and ask the surgeon whether the brain, is it pulsatile or not. Okay, you can look at it, whether it's ischemic. Sometimes when open, the brain is ischemic. So the surgeons might need to cerebral protect the patient in the ICU, so you do not have to extubate the patient. Okay, of course, post-operatively, the BP control has to be good. All right, the BP control has to be good so that the cerebral perfusion pressure is being maintained. If the patient's preoperative GCS is good, all right, so we can allow weaning. Okay, if the surgery or the brain is uncomplicated, so that the early neurological assessment or GCS assessment can be done urgently or fast. And then some patients will have a very bad cerebral edema operatively. They may need a tiopenton coma in malignant cerebral infarction. And can, of course, sometimes some patient may have DI, diabetes insipidus, that are managed. And if let's say the patient is keen, we can ask the family members for organ donation. All right. Okay, so the final part of my talk, I'll be talking about cranioplasty. All right, cranioplasty we frequently see in our center in Queen 2. It's a surgical repair of a skull defect due to a previous surgery. And this repair is commonly done about 6 months after the injury. And there are many prerequisites by the surgical side on whether what are the indications. Most importantly, that the patient is GCS, the Glasgow Coma scale is good. It's more than 12, more than about 15, then it will be okay for them to do a cranioplasty. And importantly, if the patient is already ADL, okay, ADL independent, is working and to prevent a trauma on the brain because of there is no skull. Okay, so it's very important as for cosmesis purposes. Commonly, the materials used can be like autologous. Okay, the own skull defect they usually put in the bone bank and then you put it back to the patient. That's the best, and then it be the fastest. Okay, for the autologous. They can use the implant such as a titanium mesh, which is shown over here. This 3D reconstruction, a bit expensive. Okay, 3D reconstructed prior to putting up into the defect. Okay, it can be titanium, it can be acrylic. So the patient even go for MRI later on for any type of injury, it'll be safe, okay, for the patient. I already mentioned indication for cosmosis purposes and to prevent intracranial hypotension. Okay, when there is a defect in the skull, okay, so when there is a skull is out, so the pressure from atmosphere is higher, so it will cause a higher effect on the brain. So what happens is that because of the intracranial, the pressure effect on the brain is lesser compared to atmosphere. So what will happen is that we can cause the herniation of the brain inside the skull into the foramen magnum with prolonged condition. So therefore, they usually have to put it back so that it's more physiological. Okay. And of course, you want to protect the brain from further trauma because of, let's say, he's active in sports, all right, active in work, sometimes construction, all those things can occur. So you can prevent the trauma on the head. Okay. Complications of cranioplasty like bleeding, site infection, CSF leak, seizure can occur, and this pseudomyelomeningocele. Okay. So site of cranioplasty are usually a supratentorial region, so it can be frontoparietal or temporoparietal region. Depends on where is the defect. Rarely they will do a cranioplasty at the posterior fossa. Okay, they never do. Although let's say you say the patient had the bleed, okay, previously you got a posterior fossa bleed, and of course they'll do just a small incision at the posterior fossa there in a prone position. Okay, but because of our scalp is very thick, they are very muscular, so it's very easily closed, and there is no cosmetic problems with it. Okay, the more important is more to the frontal part of the brain parenchyma. brain tissues here, okay, whereby it's a larger, okay, incision rather than a posterior fossa. It's just a small nick, okay, about maybe 4 or 5 centimeters, okay. Then it's not really cosmetic purposes, okay. So these are the things. Okay, so we had done before about 1 or 2 cases for awake elective cranioplasty. It's good that this can be done, all right, because of this. Sometimes the patients we have to carefully choose. It's not all any patients that you can choose for awake cranioplasty, okay. Indication because of let's say the short duration, less than 2 hours, minimal bleeding is anticipated, and of course in a normal supine position and the defect is small, all right, and the surgeon has to be very competent and quick. Contraindication, of course, patient refusal, altered GCS, patient is uncooperative, okay, inability to lie down for long duration, especially the elderly. So we rarely do these things, okay. Yeah, so we have to carefully choose the patient for awake elective cranioplasty. So how we usually do is that the patient is awake throughout this surgery, and we always employ monitored anesthetic care, AMAC. And the anesthesia we use can be either various IV agents, okay, like remifentanil, or infusion and dexmedetomidine, Presidex, okay, scalp block, and LA infiltration, okay. So again, we know about Presidex. The pharmacology of it is a alpha-2 agonist, very potent and binds to the pre and post-synaptic neurons to prevent the release of noradrenaline. Okay, so it is good that it is no respiratory depression for this patient, and the patient, and this drug will reduce the need of the CMRO2 and ICP with the maintenance of the cerebral perfusion pressure. Okay, so the patient will be awake, will be will be sedated, but the ventilation is being preserved. Okay, so this is a very good thing of Presidex because it can create a analgesia component as well, right? So patient preparation, yes, of course you have to tell the patient, consent, explain to the patient and surgeon regarding the need and our preferences of doing this awake cranioplasty, and make sure the patient is in supine position. ASA monitoring like NIBP, ECG, SpO2, capnography, and BIS monitor is important. Provide nasopron oxygen with capnography, and 2 large bore IV lines is adequate. One is for fluid maintenance, another one is for your drug administration, and of course, patient has to be kept warm. All right. This is our bispectral index. Okay, if you don't know, we always maintain it around 60 to 80 for just sedation purposes. Okay, because it's not an anesthesia, it's just a monitored anesthesia. That's why you can put a BIS on it. But again, depends on the location of the defect. Okay, the defect. So sometimes the surgeon might, the defect is too anterior, so you might not have to use the BIS monitor. But you can communicate with the patient regularly during the MAC, okay? So what we usually do is that we use Presidex. We will use and load Presidex over 10 minutes, and then we maintain an infusion about 0.5 mic per kilo per hour. And then you may need to put in extra boluses of fentanyl or remifentanil, okay, for extra analgesia, just in case the patient is uncomfortable. And more importantly, you can give a scalp block to the patient, okay? The scalp block for the patient is important for intra and post-op analgesia. So what I always use is that I use chiroquine, okay, levobupivacaine, about 0.5% with adrenaline. Okay, adrenaline is 5 mic per mil, so it will comprise a duration of analgesia up to 8 hours. Okay, post-operatively, it's very good for the patient. So, okay, so you can do it in the operating room itself. It's just a very simple, about 5 minutes procedure, so you can do it. Okay, so for me, I always use levobupivacaine. It's about 20 mils, and then adrenaline 5 mic per mil in it. So of course, you must find the toxic dose of your LA first before you infiltrate this LA into it. The anatomical sites are supraorbital. Okay, if you treat about 2 mils in supraorbital, and the supratrochlear region, and then the auricular temporal, okay, and then the zygomatical temporal is somewhere near here. And of course, we look at the posteriorly, you get a greater occipital. Okay, we look at occipital protuberance over here. You can see the heart link. So lateral orbit is a greater occipital nerve, and also another one is the lesser occipital near the ear. Okay, just about 1 centimeter posterior to the pinna is the lesser occipital nerves. So there are 7 nerves to be blocked. The acronym is SASAZO, S2, A2, Z, O2. Okay, so each side you put it as about like a sausage shape. Supraorbital, supratrochlear, and auricular, zygomatical temporal, greater occipital, lesser occipital, and the greater auricular nerve. So 2 mils each, maximum is about 15 mils in total for a patient. So it's still safe within the toxic dose if the patient is about 70 kilos. All right. So adrenaline is added to prolong the effect of the analgesia intra and post-operatively. Again, this is the diagram of the patient. All the nerves are involved here. Okay. And intraoperatively has to be vigilant. All right. Vigilant on the patient's comfort. Whether it's patient pain, obstructed airway, restlessness, discomfort, nausea, vomiting, seizures, shivering. So sometimes patient will be having a productive cough, not necessarily because of he having COVID, but sometimes VAE, venous air embolism may occur because of the pores of there's a venous system at the brain, at the bone, at the skull area. So the air might be being sucked in, and then it will go into the right side of the heart, go into the heart area, and then it will cause a reduction in the cardiac output. Patient will have hypotension and bradycardia and can asystole very fast. And of course, LA toxicity has to be observed. Okay, so what we always do is always have to have a good communication with the patient. All right, make sure it's comfort, observe the patient carefully, and of course, we have to be ready to convert to GA anytime. Post-operatively, no need, not necessary to admit to the ICU or HDU, monitoring the ward for pain. All right, the APS team have to be monitoring the patient very well to see for if there is any pain. Okay, sometimes, usually if it is a good scalp block has been given, pain is very good. All right, the cover is very good. You can allow the patient have clear fluids up to 2 or 4 hours post-operatively if no complication, and if there's nothing wrong, you can discharge the next day. All right. So usually in HUSM, when I was practicing a master's in University of Science Malaysia, Kelantan, we do it as a daycare. All right. If we have chosen the patient properly, all right, they can be do a daycare in the afternoon, you can just discharge if there is no complication. All right, with this, I end my talk today in the afternoon. These are my references for my talk. Feel free to ask me for further questions. Thank you very much and have a wonderful day ahead.